This conference will now be recorded.
So welcome to AnCan's Blood Cancers Virtual Support Group. It is March 2nd. I can't believe we're in a new month. And we're here. We have people who will probably be joining us, but I just want to kick it off. I'm Michelle, and I'm in Boston, and I have CLL. I'm going to hand it off to my other moderators.
I'm Sally, and I live in Indianapolis, Indiana, and I have multiple myeloma.
And I'm Lynn deep in the heart of Texas, and I have CLL and or SLL, and I have a brand new doctor, so I'll have a report later.
Ooh.
Al, you're muted, Al.
Let me open my window, see if I can hear you, Al.
Hello, I'm Al, and I'm down in Tucson, Arizona, and I have polycythemia vera.
And hold on, that's not all you want to say. You're a moderator, so go on, make your announcement.
If you could please mute your mics when you're not in conversation, just to avoid all the noise. Thank you.
Thank you, Al.
Thank you. So Judy, welcome. You didn't miss, I just saw your face pop on. I think you've been on, but welcome. It's nice to see your face. So we do not have any newbies, but since Holly was away for a while, Holly, do you need any time this evening to share? And I'll make sure that we leave some time for it.
Nothing really to share for other than New Orleans has bugs flying all over the place because it's like 84 degrees here. But I might need a little time just to share my story since it's been a while.
Great. Jim.
Yes.
Would you like some time this evening?
Anyway, I'll take a little, sure.
All right. So good to see you. Going around, I'm trying to go like clockwise. Sally.
I do not need time, but thank you for asking.
Bärbel.
No, I don't need time today.
Thank you again for being with us. I still can't get over that, what time it is for you. And here I complain. I'm not complaining anymore, 8 p.m. You look at Bärbel and what time it is for her. Mary, how about you? Oh, you were unmuted for a second. We can come back and see if Mary needs time because now I think she's frozen. Judy, do you need time this evening? You had a lot going on, if I remember, last month between you and your husband.
Maybe a little bit.
Okay.
Not very much.
I'm trying to go around my screen, but people keep switching. Lou, we haven't seen you in a little while. Do you have anything you would like to share this evening?
I had a visit with my oncologist today, a myeloma specialist, and so I'd like to share that news.
Oh, very timely. Mary is, we'll come back to you, Mary, anyway. And Lynn, you said you want time and because you have a new doctor, Al.
Yes, I'll have some time later. I like to bring something up.
Okay. Okay, this is wonderful. Okay, I'm trying to see who has not been here in a while. I do think that's, Holly, would you rather share now? Would you rather wait until after things get going?
Yeah, I'll wait and see how things are going, and then I'll share.
Okay.
Joe Rosenbaum in Pensacola, Florida, and I want to share a new treatment that I'm going to have next week.
Go ahead, let us know right now.
Well, my oncologist at MD Anderson and the oncologist in Pensacola have agreed to give me an injection of new medicine that I haven't been on yet.
And
I'm
what is
looking right. Give me a second.
I wasn't prepared, so I'm looking for it. To see where it is. But it's something to enhance his red blood cells. It was just passed the FDA, and even though he's been in remission a year, he's starting to need transfusions. So it's a new medication for that. And as soon as I find the name of it, I'll spout it out to you.
And Joe, how are you feeling? Because you were telling us, I mean, a lot of things were not improving.
Joe, what do you have?
MSL.
He has MDS,
MDS.
myelodysplastic syndrome.
And in this, that an MPN? I know all this alphabet soup, right? Is that an MPN, a myeloproliferative neoplasm? I can't recall if it is. I know that Al's is. Al, do you know if?
I can't find it. Oh, this drug is called luspatercept, luspatercept. And it's supposed to help his red blood cells. It just went through a clinical trial at MD Anderson, and they FDA approved it.
That's good.
So
That's
yeah,
good. Has something. Yes, and it's not an MPN.
No.
Just throwing that out there, but I know that it's its own. We have someone else who just joined us. Hi.
Hi.
How are you?
Oh, good. I'm Lisa.
Thank you for joining, Lisa. We were just people were sharing, but since you're with us, thank you for joining.
Oh, sure.
So how are you feeling?
First time.
How are you feeling, Joe, about this, adding this on?
Well, I don't know how I feel until I start taking it and see if it improves my red blood cells. I'm looking forward to adding something.
Well, he's just started having to need transfusions, which he hasn't had in a year. So, I think it's built up a lot of iron in his system and everything, and they're just trying to keep his blood cells, boost his blood cells. Has anybody else had their red blood cells boosted? No. We also have a friend who just got diagnosed, and I've sent her with some kind of a blood cancer. I don't know what it is yet, but I've sent her the AnCan link, and I asked her to go ahead and register. I don't know if she's ready yet because she just got diagnosed, but I told her.
We see quite a few guys getting their red blood cells boosted in some of our other groups when they've been on chemo with drugs like Procrit, if I'm not mistaken. And there are a number of drugs that have been around for a long time, three or four that are used, but they're usually used very carefully, and I'm not really sure why. It's not really my area, but I do know if Herb were here, he'd be able to tell you a lot more. But it's not uncommon with chemo to get red blood cell boosters. Sally, you're so good at this stuff usually. What do you know about red blood cell boosters?
Well, good. Come on. Well, the good and the bad about multiple myeloma is no one needs red cell boosters. We need immune system boosters. So we have things like IVIG all the time. I don't know anything about red cell boosters. Sorry.
It's okay.
Okay. We're not strong on red blood cell boosters. I mean, I know we use them, but I do know that they're used very sparingly. The Procrit is anyway.
So
So this,
if you're low on red blood cells, does that mean you're anemic?
Yes.
Yes.
So I just thought they gave you blood transfusion if you were anemic.
That's what I've had in the past, but this must be, Joe, is this something that they usually give when you have MDS? Is this they give along with treatment?
I don't think so. I just think that MD Anderson thought they would try this in order to eliminate the blood transfusions.
Could your wife spell that drug again?
It's in
Yeah.
chat. It's
Oh,
in
it's in the
chat.
chat.
very good, very good.
Thank you.
Yeah.
Yeah, so he was having to have transfusions a couple times a month, the last 2 months. So they wanted to try this to see if they could build up his red blood cells so that he wouldn't need the transfusion. We'll see.
How low does this red blood go?
Um, oh goodness.
I have a friend in San Antonio whose wife has some type of blood cancer. I don't know what kind, but they're having to give her blood transfusions just about every other day or so. I'm going
Yeah.
to pass the name of that drug on to him.
Yeah, he's down in the twos. 2.02, 2.13.
Wow, I would think he'd have a transfusion with that for sure.
Yeah.
So I think that this is an alternative to giving a transfusion, and there may be less risk involved in getting a red blood cell booster versus getting a transfusion. And it's more targeted. But again, I am not the expert here. Sorry.
Well, the good news is he had a bone marrow biopsy get this last visit, and he's still in remission, so that's good.
Okay. Okay. Well,
That's
sorry,
it.
we can't give you
That's,
more information.
that's all
We
right.
can find people. We may be able to find people who can. So if you reach out, I may be able to connect you to a couple of people that might know some more. But I did put a couple of links in the chat window. One is this new drug they're trying you on, luspatercept, which is commercial name is Reblozyl.
Mm-hmm.
And I also put some information about Procrit in there. If it were me, I might be asking my doc, what is the benefit of this luspatercept over something like Procrit? It may well be that Procrit is just not appropriate for an MPN like yours, but I don't know.
Well, no, they did say that because our local oncologists and the pharmacy are having a little difficulty getting the drug, The doctor at MD Anderson said there are some other ones that they could put him on if they can't find it. But evidently they found it this afternoon. So
Good.
yeah,
All right.
thank you.
Where was it? Where was it? They found it. Do we know where it got to?
It's not in Pensacola.
Oh, it's not in physical. Okay, that's okay. Just asking. Okay. Michelle, back to you. Maybe we should spend a little time with our new lady.
Lisa, thank you so much for joining us. Welcome.
Oh, thank you. I learned about the group from Lynn, who, so I thought, well, I'll join, I'll say hi. I always feel like getting support is helpful. I really like connecting to other people going through the same sorts of things. I find it helpful. Do you want me to explain what I have or? Oh,
Sure.
okay. Okay. So I was diagnosed in May of 2021 with hairy cell leukemia, and my blood levels were very low at that point, and so I had to start treatment right away. And I received a chemotherapy. I received cladribine and rituximab, and I did pretty well. I needed to be hospitalized for about a week with a neutropenic fever. And that was unexpected. That was not good. I think, I don't know really what to say. I guess for me, I just think especially last year, I just felt like a very intense period. I think I was very shocked by the diagnosis. And I think for me, probably more than anything, at the time, my children were 7 and 9. So I think for me, like looking back, I've been reflecting on this a lot lately, like kind of thinking, looking back, and I just think that it it was difficult. I think sort of dealing with the emotional and physical parts of the illness, and then trying to equally really focus on the kids and making sure they were okay with everything. I think that like those that was difficult. But I feel like slowly kind of coming out, I had to be really careful with COVID because of the B cell depletion and some of the, I have T cell depletion, or I guess some of my T cells are low due to the chemotherapy. So during, so I felt like, especially last year, I had to be really pretty careful about COVID. So I feel like, I'm really hoping. I'm in the Northeast. I'm just outside of Boston. So I feel like as the spring and summer come, winter's hard around here. And I feel like I'm really just looking forward to, maybe being out a little bit more and engaging with people. And I don't know, I guess the integration of kind of having a chronic illness maybe takes time to adjust to. But just trying to take one day at a time and just take really good care of myself as best I can. And I feel like the overall summary.
Oh, thank you so much for sharing. I'm in Boston.
I thought so. I actually I found you on Instagram.
Oh,
You have yeah, and I noted that you're from Boston, and I was like, I'm from Boston, yeah. So I felt like, oh, that's really nice. Well, it's really nice because I don't, I think my other connection, like my friends, everybody is really in like, people, everyone, my immediate friend circle, everyone's super healthy, or they don't have a chronic illness. So while they're supportive, it feels different. I mean, it's like it's sort of tricky. I find that I don't know. I kind of hold back. I don't know. It's just I find that it's easier to talk with people that maybe have the same sort of concerns, or so it's really nice. Like when I saw that you were from Boston, I thought, oh, that's so nice. Like it
aw.
just feels connected. It makes it. I guess what I'm trying to say, very inarticulately, is that it's a reminder that there's other people going through sort of similar things and struggling with, I think, not only the physical part of it, but just also the, you know, the fear and the anxiety and all that stuff about what this means going forward in your life in the future.
Uncertainty.
Yeah, exactly.
Where are you being treated, Lisa?
I am being treated at Dana-Farber Cancer Institute.
That's great.
Okay, so are we going to start matching names, Miss Michelle? Doctors' names?
Well, it would be different because I know, well, my doctor only sees CLL patients, so I'm not sure because they're so specialized at Dana-Farber, but I see Dr. Jennifer Brown.
Yeah, I see Dr. D'Angelo.
I know his name because anyway, my father-in-law's neighbor goes to Dr. D'Angelo, but for something different than what you go for. He's a firefighter, and he actually has, I'm trying to remember what he has. I want to say, but I'm going to get it wrong. He has an acute leukemia, but not acute myeloid leukemia. It's another one, and I have to look it up. I've been trying to get him to come to our group, but he's been fighting it. So
I know it's hard. Yeah, I mean, yeah, hairy cell is so rare that he said, you know, nobody really specializes. There's like one specialist, I think, at NIH or something, but he said, you know, it's rare, so it's, you know, most oncologists, you know, specialize maybe in a broader array, you know, but we're lucky, I think, to be close to a major cancer center.
Absolutely. And so what are you taking, or what treatment are you on?
Well, I was on, I'm not taking anything currently. I was on cladribine, which is like, I had 5 infusions, and that's a chemotherapy drug. And then, which is sort of they've been using that for a long time. They find it to be effective, but they found that adding rituximab, I had 8 infusions of rituximab. They found that that pushes it deeper into remission for a longer period of time. So, you know, so I had that, and then, you know, now I'm doing okay. I'm definitely, you know, doing okay. I think, I often wish it was just curable. Like I have friends, you know, for instance, that have like, well, not many. I have one friend, actually, I should say. She has like breast cancer, but it was removed. She, you know, had it removed, and she said it was like she wanted it out of her separate, and, you know, she could sort of separate from it. And I said, it's so weird. I said, it's just a different mental game, I think, thinking of something that's not really curable. It's in your bones, you know, it's in your marrow, but it's manageable. So I guess, I mean, that part is very positive.
So Lisa, I want to say something on that. In that many cancers, if you catch them, many solid tumor cancers, if you catch them early, they are removable, and they are so-called curable. But most solid tumor cancers that are a little bit more advanced, it's the same situation. You can't, I mean, I had a stage 3 prostate cancer. I can never say I'm cured. We don't know how to cure that yet, because it could have gone anywhere. And even though I have a durable and continuing remission since 2011 or 12, each year I got to go back, and each year it could pop up again. And sometimes it does. So I'm telling you this only because don't feel like it singles you out. That a lot of people with cancer, if they caught it a little, they didn't call it very, very early. I mean, like if you have DCIS breast cancer and they chop it out very early, yeah, you know, we can talk about cure. And There's some forms of some type of prostate cancer they get very early. It's great, but it isn't. It's similar to the blood cancers very often, and so you learn to live with it, and then we get into this whole other area, which we at AnCan are doing a lot of work in this year, which is how you deal with the anxiety of living with a chronic illness.
Yeah.
And one of the things that we see certainly in the genitourinary cancers like bladder and kidney and prostate and testicular is that the doctors do a crummy job. They don't identify this anxiety, and they don't help you in navigating you to people that like these support groups where you can talk to other people. I mean, I know that there are people sitting in this group right now who are dealing with similar anxiety to what you've been talking about. And it's a great topic to talk about. And maybe they'll speak up and say, yeah, me too. But don't feel like you're alone in this, because you're not. Is that true, Miss Michelle?
It's very true. Absolutely. And every time, different things happen, it reminds us and rears its head. With a relapse, like what Rick was saying, or with those of us who also have chronic conditions like CLL is chronic lymphocytic leukemia, but also multiple myeloma, there is no cure for.
Multiple myeloma is not even chronic yet. They say multiple myeloma is still incurable, but they're getting, every year they say we're getting closer to a cure. And if someone got multiple myeloma in, say, 2005, they were told they had 3 to 5 years to live. They haven't really changed that. If you still look on Google, it still says 5 years maximum. But in every support group, there are people who have been, dealing with multiple myeloma for 12 years, for 15 years. I'm going on my 5th year. Lou is 10 years. And every one of us just wait for the relapse. I mean, that's, even though I'm going into my 5th year in remission, every time I go for blood work, I can't, that 2 days of waiting for those numbers, it's terrible because we don't feel any different when it relapses, but your numbers all of a sudden show you're in a, clinical relapse. I think Lou can tell us a lot about this. She's done a lot of this and different clinical trials, so she has stories about that.
I think Jim just unmuted his mic.
Yes. Some kind of a question. Do they think that there is some kind of a gene error that could cause this? In other words, genetic testing of some sort.
For hairy cell?
Yes.
Oh yeah, there is. Although it was early on when they were doing when they were trying to figure out my blood levels were low, they did genetic testing, and I did have markers.
Okay.
Yeah. I wish I could tell you. I should know this. I feel like I'm usually pretty up to date on stuff, but I think during that time it was a little bit of a blur, and I haven't gone back to look at that. But I just remember asking the doctor, do I have this? And he said, yes, that's, what you have. So.
Now, are those some kind that can be passed down to the children?
That's a good question. I think at least the one for hairy cell, he said no, that it's not one that because I asked that too. That's pretty much the first question I asked. And he said, they don't know. When I was in the hospital, I asked the team of doctors, I said, I don't understand. How did I get this? And he said, we don't know. We don't know if you were exposed to an environmental thing, or we have no idea. He said, it's so rare that he said it's like you were you happen to be standing somewhere where a beam of light came down, something came down from the moon and hit you. He goes, it's just extremely rare. He said, so because of that, he's like, we don't really know why this changes, except for that it is, we don't think that it gets passed down. I mean, that still makes me nervous just in a broader sense for the kids, just if there's something they don't know or they haven't tested for or whatever. But at least from what now they've kind of reassured me that it's not something that I should be worried about yet that I should be worried about for the kids.
Yeah, that's
I
long
hope.
coming.
Lisa, it's so rare, Lisa. Have you run into anybody else that has it?
Well, I connected with there's a Hairy Cell Leukemia Foundation based out of New York. And so Hairy Cell tends to be mostly men. So it's, there's less women, but they're pretty much, I mean, there's a couple other women that are part of the Hairy Cell Leukemia Foundation, and they have kind of similar things where they have coffee chats and stuff. And so it's super helpful. Like I really like hearing about how other people are doing and how they're dealing with stuff. And I just find it really helpful. I feel like the support, the connection.
It is important, and it makes a big difference. And luckily there are things like this now, because those of us who have had something for a while, there weren't things like this.
I know.
Lou, you and I have had, we've had cancer for around the same amount of time, and there wasn't anything. And by the way, I'm curious, Lisa, if in 5 years they have different numbers and saying it isn't almost all men for hairy cell leukemia, because as Holly and I can attest, and Bärbel, CLL, they say, is an older man's disease, when in fact there are so many women that we've met online with it,
Right.
younger than the ages they say, that who knows?
Like they haven't updated it or something.
You would think, but it also could be, sorry, gentlemen, that wasn't your fault, but the years that, the years that we're usually diagnosed are the same years where a woman, they could blame it on so many other things. And
Right.
so
Myeloma is supposed to be an African American male disease of over 65 and normally a farmer.
Wow.
And we have 3 women here on this site that are multiple myeloma people. And we're not African American.
So yeah. I wondered a lot, like in the beginning, how did this happen? But then I did kind of let that go, because I thought I don't, unless they do a study, unless they find it, I'll never know. It'll just be, I just have to accept it. Or
if you think about genetics and how a cell divides, and how many times a cell divides a day, let alone in your lifetime, and a mistake is made, and then that mistake is just transferred and transferred until it causes a problem. There doesn't have to be a beam of light, or you ate a green leaf that was the wrong thing, it was a weed instead of your leafy greens, or you drank something you shouldn't have. It just happens.
that's
It's like,
right.
it's like you get a freckle. You got a freckle because, the cells were dividing and they had more pigment in it. And so the next one, they got more pigment and they got you, so you got a freckle. So
Right. Yeah, yeah, it just
you can't
happened.
worry about how you got it.
I agree. Yeah.
yeah, that's something that we all, I don't know about everyone else. I remember I went through that. It's like, how did this happen? How did I get it? And then I realized one day that it really wasn't doing me any good, and I would never figure it out. Sure, I could speculate, but it's not like it's going to change the course
Right.
of what happens, and
Well,
it's wasting energy.
if Queen Elizabeth can have multiple myeloma, and mummies that have been found, that are 3,000 years old, have indications of multiple myeloma, there's, not one thing, whether it's Agent Orange or DDT or, Fritos.
Yeah, who
So,
not, right?
Queen
Do,
Elizabeth had
do you all
multiple
think,
myeloma.
yeah.
Yeah, so those with multiple myeloma have a queenly, just at least something that's queenly.
But I'm disappointed that they kept it from the public until after she died.
I know, right?
Me
That could
too.
have been a rallying point or a good, you know, introduction and awareness situation, but
Right. Do you guys find that like the more time goes past from your diagnosis, do you feel like you think about it less? That you, or not really?
but I'm a coach, so I'm questioning things daily and with different people and different stages of their disease and from the wide eye, you know, deer in the headlights, you know, I don't know what's going on to
Right.
people who have a lot more experience like Lou. I mean, I go to Lou for answers.
That's
So,
nice.
Well, so with Lisa sharing all that, is there anyone else here going through a tough time right now with their diagnosis or treatment, or perhaps upcoming treatment? Judy, or did you
Well, I'm kind of in the waiting game, which is kind of unsettling because mine is becoming more active again, and I know you've probably gone through that too. But when you're waiting to say at what point you're going to need treatment again, and I think the thing that I expressed to Dr. Awan this last week was because my other two times that I had treatment, it came up very, very fast and developed very fast to where I needed treatment. That really makes me, and that's what I said to him. I said, I want to keep a handle on it because the other two times it started so fast. I don't want to, you know, be 6 months and yeah, it's happening. And that's why we're kind of keeping a wrap on it for every couple of months.
I remember you you had mentioned that before, and could you remind me, were they worried ever about Richter's transformation because you
Actually,
relapsed?
my second time was Richter's. I had large B cell lymphoma in my colon and had half my colon taken out. And the strange thing about that, I was talking about coming up so fast, is I had just had a colonoscopy 9 months before. So, you know, that's a very quick, to me, change.
Yeah, considering they only have you do them every 10 years.
Well, no, I'm down to a couple of years now.
In general, I mean, though, that's so
Yeah.
quick. And with
Yeah.
and was that because you escalate, your disease escalates more quickly, that can happen, the transformation?
I don't know. It's just, you know, it was like when I was first diagnosed was in December of 2014, and it was October of 2015, less than a year, that I had an excised lymph node under my arm. It started my very first treatment. So everything was less than a year developing.
Wow. That's really, really quick. And Judy, you're not on anything right now?
No, we tried after I finished my, of course I had chemo, really strong chemo, the REPOC, and I had, we tried to take a calibrutinib, and because my neutrophils were so low, we only did that for a couple of months. And this has been, I haven't had chemo since 2020, and it was like May and June of 2020, we tried a couple of months on the calibrutinib and then stopped it because my neutrophils were just so low.
Wow.
And I was taking lots of neutropenia shots.
But your CLL's it's just started. It
Started
seems promising.
with lymph nodes. I had a what do you call it? A PET scan the 1st of January, and he's saying that probably three to 6 months I'll probably have to start treatment again. But you know, my thing is I want to keep really close tabs on it because everything has developed so quickly.
That's very smart to know that, to realize that, and to advocate to be seen more frequently. Good for
Well,
you.
because I still have a port. I have a blood test every month, and because you have to have it flushed every month. And I said, if you're going to stick me and flush it, you might as well take my blood and check it. so every month I have a blood test.
So if he said in January, maybe 6 months, so now we're down 2 months.
Well, no, I just saw him. In fact, Lynn and I saw him both at the same time last, week before last, the 23rd of February.
Did you see each other in person there?
Well, we actually saw each other the first time in person, before my appointment, and I think Lynn's was right after mine. So, yeah.
How did
We had
that
a
feel?
nice, we had a nice visit.
Yeah, it was a nice visit to
I
actually
love
in person.
I love that. I love it when AnCanners get together and meet in person. It is so powerful. I mean, it's unbelievable.
Did you get a picture, you two?
No.
Oh no, because we would put it on the blog. We put it on the blog when that happened.
We'll have to coordinate our appointments again. Except he doesn't go as often as I do.
Wow. Well, so
I'll see him every 2 months, 2 to 3 months.
Lynn, how often? This was your first appointment with Dr. Awan, right?
Yes, he wants to see me in 4 months.
So maybe.
But there's a lot of testing to take place between now and then because I've been on ibrutinib for 9 years, and he is offered the option, if everything looks good, for me to come off of ibrutinib and get a drug holiday. So then I can, I can enjoy a watch and wait like the rest of you enjoy watch and wait, or watch and worry. Because my first watch and wait was only 3 months long.
I have one more comment and I'll stop. The one thing we did, though, the last time he did do a blood test for CD4, 6, and 8 of T cells or whatever. And so I'm off of my breathing treatment that I've been having every month because I haven't, it's high enough. So I've been doing those for 3.5 years. So
well, that's good news.
Yep, that was good news.
And it's great that you're having your own drug holiday now. Totally, it sounds like. We all like to hear that.
The test was for CD 3, 4, and 8 for T cell subsequent set, which evidently has to do with your immunity. And I was having the pentamidine treatments to keep from having pneumonia.
Huh. So that's really, really good news then. Do you get IVIG?
I had been, and that's a kind of a strange thing too. I mean, it for months it was below, the 500 and 600, and then all of a sudden it jumped up to 1300, and now it's like 1800.
What are you doing? Please share.
I don't know. Even Dr. Awan was kind of baffled with that. It's above the high cutoff even. So
Are you
Okay.
talking about IgG or
Doing it.
talking about,
IgG. Yeah, it's like
yeah,
1800.
mine's below 400.
Well,
Yeah.
I
I'll
had
take some.
I've been that way, and I don't know, what happened. It was just like the first time it went up to 1300, we did the test again because we thought there was a mistake, but no, it came back the same. So
It's
who knows?
Michelle, can you explain to us,
IgG
for
is the
those of us or
secondary.
some, yes. Go ahead,
I was about
Sally.
to.
Yeah.
IgG after IgM is the first antibody whenever you get an infection. Doesn't matter what kind of infection it is. And it's the first one that goes after anything. IgG is the standard one that is used the most, is more general immunity for colds or flu or anything. And if you get any kind of inflammation in your body, doesn't make any difference if it's a tooth or a toe, your IgG will go up because it is fighting some sort of infection.
Uh-huh.
Which may be with my lymph nodes, who knows, becoming active. Maybe that explains it.
Yeah.
So the
Well,
higher
that
it
explains
is,
why my IgM all of a sudden went up.
the higher
What?
it is, the better, because it means that your immune system is better. Is that right? You're fighting, you have more to fight. Is it a good sign that it's high or a bad sign
Well,
that it's
no, it
high?
means you're fighting.
You're fighting something.
I
It's
see.
just it's a sign that it's fighting something. And if you don't know what it is, it's sometimes important that you go find out what it's fighting.
Got it. Got
So,
it. Got it.
but if it's lower than range, that's not good either. So that means that you're really low on your
No,
level.
because you
It's
can't
like a
fight
fine,
anything.
Can't
it's like,
fight.
Yeah, that's when my IgG goes down below 400. I get IVIG.
Yeah.
Just to boost it up.
You get it by IV or you get the subdural,
Oh.
subcutaneous.
What, IVIG?
Right.
IVIG is about a 5-hour infusion.
It's also available
You get it
through
like what he,
subcutaneous.
yeah.
So I opt to get it through IV. I had tried subcutaneous once years ago, and I had some really bad reactions. Now that could have just been, it's since been explained, it could have been the brand they were using. It could have been the latex maybe that the little subcutaneous gizmo was attached with. But so I've been getting it via IV.
I get 4 bottles that are this big. I get 4 bottles that are this big. They could never do that, sub-Q.
You get that much? I usually get one
Yeah.
bottle.
I get 1.5.
I get 4.
Wow.
So Michelle, were you getting subcutaneous once a month or every week?
It was so long ago, and it's before I was ever diagnosed with CLL, which is interesting. But if it was via IV, it was once a month. If it was subcutaneous, I had to do it more frequently, I remember. But I only had it a couple of, I made it through like a half and then another half, and they just stopped because my reaction was so severe. So, yeah, never again on that one. Maybe I'd try it again now because that was a long time ago. But Lynn Hutt, so you made out okay, and you might be getting a drug holiday. This is really great news. How'd you like Dr. Awan?
Like Dr. Awan real well. Farouk, Farruhg or GH or KH. Dr. Farouk Awan at the UT Southwestern in Dallas. I've been going to MD Anderson since 2013, but my doctor at MD Anderson is out for an extended period of time, and they're not sure when he's coming back. And I saw his PA last August, and they were scheduling me to see the PA again this coming August. And I said, rather than come back for my 6-month checkup, which is in February, I would like to go see a doctor in Dallas. And they were okay with that. It's half the distance for us. It's much easier. And back about 2015 or so, Dr. Samaniego at MD Anderson told me he could turn me over to a doctor in Abilene, and I wasn't ready to at that point to go to another doctor who knew little about my disease. But Dr. Juan has such a good reputation. I was really, really impressed with him. They took 16 vials of blood, and he's wanting to confirm the blood counts. I've got CAT scans scheduled. I'll be seeing a pulmonologist. I'll be having some breathing test done. I have some lung idiopathic pulmonary fibrosis. They don't know what the cause of that is, but anyway, I think he's wanting to kind of push away from ibrutinib. He also raised the concern about heart issues with ibrutinib. Of course, we know about AFib, but he is concerned about other irregular heartbeats. They did a electrocardiogram that day in the office. So anyway, I am pleased with him. Looks like I'm going to be going back. Like I said, I see him in July, but I'm going back about 2 times a month between now and then to see these other doctors. I'll also be seeing a benign hematologist to talk with him about a blood clotting disorder I have, which causes me to be on blood thinner. I'm on Coumadin or warfarin, so I'll also be seeing that doctor. Um, I have factor V Leiden, which is a genetic disorder that nobody else in my family I know of ever had it, but it can cause some clotting issues. My first blood clot in the leg was about 20 years ago, and then I had another blood clot in the leg about 10 years ago. So it seems like blood thinner is a good thing, but of course, ibrutinib is also tends to thin the blood, so that's a concern.
Yeah, it
So,
messes with your platelets, with the
yep,
integrity of platelets. Wow. So too bad the ibrutinib couldn't take the place of the Coumadin, right? And you could get a twofer, but
that's right. Yeah, and of course, I raised the question with him about switching to acalabrutinib or zanubrutinib or one of the other new BTK inhibitors, or some of the other drugs, and he said, well, I think you could take a drug holiday. There have been some studies of patients who have been on ibrutinib and have a good deep remission that have been off for 2.5, 3 years without it coming back. So I said, well, I think that my minimal residual disease is about 1 in 10,000. So he tested that as well, and it's I think 0.01%, which would be 1 in 10,000. So we'll see what he thinks in July.
that's all good news. Maybe it's good having new eyes on you.
Yeah, that is reassuring to have another doctor. I have not communicated this to MD Anderson yet, but my next appointment there is in August, so I will let them know, before that time. But still kind of evaluating Dr. Juan and where we're going here. So, and as I see it, MD Anderson is still there. If something comes up and Dr. Juan says, maybe we need to get an opinion from them. But for the time being, I really have a lot of confidence in him. And that's always a question for us, no matter what our type of cancer is. What's the reputation of our doctor? How well versed are they? And I think if you can find some of the cancer organizations that have videos of your doctor, that's a good sign. You can find some papers that have their name on it. I think that's a good sign. So enough yakking from me. Maybe you want to go to somebody else.
Lynn, what is the fibrosis?
What is the pulmonary
Do you know?
fibrosis? That means
Oh,
it's
I'm
Pulmonary.
pulmonary, yeah.
Oh. Holly Houston's closer for you, Holly, right? Than Dallas? Or is,
yeah, it would be and a preference to like MD Anderson, if I could. I don't know if anyone knows of a CLL specialist. I know you told me, but I cannot remember where I wrote down his name.
At MD Anderson?
Mm-hmm.
There's a few. I mean, Lynn may know better because he's in the system. But Bill Weirda is the head of it, Wierda. And Dr. Thompson just left, right? Oh, also Nitin John.
JAHN.
J-A-R-I-N.
IN, JAIN, but yeah, first name is NITN. Nitin Jane, and then there's no, he left.
I know that Seymour in New Orleans has seen a new doctor there, and it's Swaminathan or something like that. SWAM and a bunch of more letters after it.
Yeah, there's only one doctor. Yeah, he goes to a system that my insurance doesn't cover, or I have to pay a lot more if I go to that system. So unfortunately, I'm trying to get around that. But
Seymour will be with us on the Blood Cancer Uncensored Zoom call on Saturday, I think. He would be a good person to talk to about MD Anderson doctor, since he's just started a clinical trial, and he also has been seeing somebody in New Orleans. But
interesting. That's good.
Yeah, that could be your local person.
Seymour is getting a triplet. He's getting venetoclax and help me, Bärbel, venetoclax and obinutuzumab. He got second round of obinutuzumab and pertobrutinib.
Yeah. He has the new drug.
Pertobrutinib.
Yeah, Loxo 305 is the other name.
So that would be the new type of BTK.
Yep.
So that's a trial then.
Yes, it's very effective. I talked to him, what was it, last week on Saturday, and I can really see a difference. And I live 2,000 miles away.
And you could see a difference?
His face was very swollen on one side.
There's a big hump here on the side, a lump, and it's going back. And he also says that his eyesight is improving.
And his clinical trial is 6 months. 6 months. That's amazing. 6 months.
That's it? He doesn't have to stay on anything afterwards? Like the pertobrutinib, he doesn't have to stay on?
No, it's time limited to 7 months. And if he's not UMRD, he will have to continue for another 6 months on tisoputinib and venetoclax. Otherwise, he's off med.
Wow. And where is the trial through? What do you know what doctor or what hospital the trial is?
Dr. Jane is in charge of it.
Oh, it's Dr. Jane at MD Anderson.
Yep.
Oh, okay.
Only MD Anderson does this trial. The others don't.
And this is Seymour is treatment naive, so this is his very first treatment.
Mm-hmm.
Well, Holly, by the time you're ready, if you ever need treatment, maybe this would be approved by that time. If it's in the distant future, you don't need it. So that would be something. But I know that they have a lot of high hope on pertobrutinib. So we'll see what happens.
I know I'm always thankful for people going into clinical trials. I know it's scary, but for me, knowing that, like you said, 10 years ago, they didn't have anything. So I always thank everybody that I know. Thank you for being in a clinical trial.
They just started the trial. They are recruiting still.
So
who's Seymour?
Exactly.
He's in New Orleans.
Seymour Brown.
Is he a patient or a doctor? Who is he?
He's a patient.
Okay.
Yeah, Seymour, I think pretty sure he's on the CLL Facebook page, and he's also on Blood Cancer Uncensored, which is a Facebook page. He's on
So,
both of those.
and do you know, does he have you said he has a local oncologist or hemonc in New Orleans, as well as MD Anderson?
Yeah, but he was not
Yes.
happy with his local oncologist. That's why he's going to MD Anderson now.
Yeah, and I heard that from Harvey. I'm trying to remember his last name from New Orleans. The same thing. He ended up going to MD Anderson. He wasn't happy with his local. I'm sorry, Holly. I thought maybe we had someone for you for at least local. So Holly, with what you've been going through, I don't know how much you want to or not want to share, but
Sure.
but Lou, this is where I wanted to make the connection with you too. Lou, you had shared with us the last time you were with us that you had some really weird, was it an infection? Or people were wondering or kidding around with you that maybe it was mold?
Yes, it was.
And
I had mold in my bone marrow.
and how did that happen? Was it from an instrument, or do they know?
The main doctor who was investigating it said the only way that it could have been introduced in my bone marrow is environmentally. And that means, as my husband explained later, he said, he doesn't mean from the environment, he means introduced on instruments or in the room or something like that. So I never heard back what happened as far as any investigation, as far as the room where the bone marrow biopsy took place. I have not heard that they found anything, in the instruments, on the instruments, or in the room. But that's what I was told, that it doesn't happen within your body. It's introduced. And for it to be introduced into your bone marrow, it has to go in through an instrument. And that would have been the needle.
So did
So
that done in an office or at the hospital
in the hospital,
under sedation?
yes, well, conscious sedation.
Yeah.
But anyway, I took a 10-day course of anti, I don't know what it was called, mold.
Fungal.
And
Is
it
mold a fungus?
antifungal, I guess that's
Yes.
what it was called.
It must be an antifungal. Did you have any antibiotics before?
Not before that happened. I mean, not recently.
Because antibiotics don't work against fungus, and then if you have some fungus, they explode. Because it kills antibiotics kill bacteria, but not the fungus.
Yeah. So it was a medication that was antifungal that I have never taken before. And it had to be, I had to take it 10 days in a row. And it had to be, I don't know if it was sub-Q or if it was IV. Anyway, I had that for 10 days. I had to go into the cancer center. But they got rid of it. And I'm here to say, I'm okay.
Wonderful. So Holly, did they find a few, in fact,
Are they going to allow you back in the trial?
I got
Michelle, 1 second.
It's okay.
I had to stop the teclistamab trial because of neurotoxicities that happened after 39 days, which is unusual. Usually, if you're going to have some kind of neurotoxicity, it's going to happen within the first few weeks. I mean, 2 weeks, first few days. But for me, I was an anomaly. Me and mold and
Of course you are.
for day 39, why not, right? So anyway, it was the quirky thing. I'll just throw in the good news I got today. I'm still in remission from being on teclistamab for 39 days, which you're supposed to have it every week. And I only had it for 39 days, and I am still in remission from the bispecific teclistamab. And so I'm a believer, even though I wasn't able to,
Fantastic.
but you know, go
And
figure.
how long are you supposed to take it usually?
Well, there's a person in that we're coaches with, Cindy Brown, who is in a health tree coach, and with Sally and I, and she's been on it almost 3 years. And she does it every week. I think now she is at every 2 weeks. She has to have it sub-Q.
So for you, that's a blessing.
30 minutes. So when I talked to Dr. Abdallah today at the University of Kansas Cancer Center, he said, we don't know how long this is going to be. He said, but enjoy it while you have remission. So, and he does not throw around the R word. He uses it sparingly. And so for him to actually say, you are in remission and enjoy it, because we were saying, well, what's next? You know, what's going to happen next? You know, and he said, enjoy it. And so I'm just being monitored. So
Is this your second or third relapse?
I was counting up. I think it's 5 or 6. 1, 2, 3.
Oh, you're that far. Okay.
4, 5. This was the 6th. But it was because of not refractory. It was because of neurotoxicity.
Oh, wow, that's fantastic.
And I've had 3 clinical trials.
Right.
And teclistamab was actually a clinical trial because it happened.
You look great.
It happened within a month of FDA approval of teclistamab. So it was put through very quickly by my doctor, who I goaded and bugged and said, can we do it? You know, can we do a clinical trial at KU? And he wrote it. I mean, that's the kind of doctor, you know, that we have here at KU. He's amazing. And he's willing to stick his neck out and do extra work, because at the coaches training this summer, if you remember, Sally, I asked the 3
I was gonna say, are you going?
I am going this year. I asked the 3 doctors on our panel, would they ever do an individual patient study / clinical trial for a few patients? And Dr. Abdallah wrote it for 10 patients, up to 10. And they said no, they would never do it because it would take too much time and too much expense. But my doctor did it. And so I'm forever grateful.
Yeah. Good for you. And I'll see you July 26th.
And my husband, David, is now a coach.
Ooh,
Fantastic. He's a caregiver?
He is a caregiver coach, and he went through the
Good for
training.
him.
wow.
Just sort of like Mary Sage and her husband,
Uh-huh.
and Todd and Diane.
Uh-huh. So that was my share, Michelle. That was what I had to share.
That's huge. You told us you got your results, and that's a fabulous share. And Lou, all these times that you've been back to treatment, and you have such a fabulous outlook. I have to commend.
I have learned from so many people who have gone through before me. And, you know, Sally is one of them too. You know, I consider her, you know, just like a god of myeloma. I mean, goddess, I should say. She's taught me a lot too. I mean, even though I've been diagnosed longer, that means nothing. What means a lot is what people do with their time. You know, if they learn and they research and they ask questions and they attend things and learn things, that's all the difference in the world. And to me, as a retired teacher, I think, you know, absolutely, you hear people say knowledge is power. You hear Andrew Shore say that all the time. It has absolutely been my mantra forever, is you learn, you grow, and that's how you become your own advocate.
Yeah, knowledge is the best medicine of all,
Yes.
Mm-hmm.
and it is power. That's probably a lot of
And you
people.
have to advocate for yourself.
And that your husband's now trained. That's a great husband.
Yeah.
What a great partner.
He is awesome. I mean, he saved my life so many times when he's caught high fevers. If he hadn't have caught them, I would be, passed away on the couch. He's the one, my initial diagnosis where I had 103.4. He came home from school. He was a elementary school counselor. And when he saw that my face was red, I was out. That was my first diagnosis of myeloma. I had double pneumonia, and I would have died had he not insisted I go to the ER. And it happened again, just this last year, where I had 103.1, and the on-call doctor said, well, you could come in or you could not come in. It obviously was not my myeloma doctor. It was an on-call, who knows what doctor.
If it's 100.4, go to the hospital.
And he said, oh, well, you could bring her in or you could not bring her in. If he had not brought me in, I probably would have died, because my neutrophil count, absolute neutrophil, was 0. And that's when I had the mold in my bone marrow. That was in December. So, like I said, he's not just a caregiver. He has saved my life.
That's so sweet. I mean, that's a great caregiver.
Yes, the best.
Yeah, that's a hard act to follow. Here, Holly, I don't know if you wanted to, did you find out if you had mold or not?
I found out I did not have mold, based on what they discovered. I went in, I had an infection in my body. I've had several. One kidney infection that the infection created an abscess, and I never had a urinary tract infection or anything. It was just all of a sudden my back started hurting. But same thing here. I got a high fever, and then I had an incision in my breast from a previous procedure, and then it started leaking pus. And I mean, this had been over a year after the procedure. So you would think, like, why are you getting an infection now? So I went back to the doctor, the surgeon that did the procedure, and they said, okay, we'll go in, take a tissue sample. They sent it off to the lab. I woke up, and apparently he told me that there was some black spots under the muscle that he had never seen before, and he was concerned about it, but he knew I had CLL, so he was gonna consult with the pathologist. The pathologist got his results, and then he said he wanted to talk to my oncologist. So they said, it'll take about 10 days. So you're waiting for all this information. They have to grow mold in a petri dish. They have to grow all these weird bacteria strains in a petri dish. That all takes a few days. So after about, I guess it's been about 14 days. I'm a little impatient. I'm like power patient advocate now. Of course, I have Michelle and other friends from our group asking, hey, how's it going? Did you get your results? And it's like, that's a little helpful reminder in the back of your mind to say, okay, I need to be proactive and find out the results. Because sometimes you just don't want to know the results of the test you take because you know something's wrong. But anyway, so I went back, and I actually drove to the lab that the specimen was sent to and said, can you give me the results of the pathology test? And they said, no, you have to get that from your surgeon. I said, well, can you take my name and number and information because I haven't heard from my doctor, my surgeon, my oncologist, my surgeon, or the lab, and I haven't seen any results. And I went to it was a smaller town than New Orleans, so it was a different doctor, different area, but they're all trying to communicate. But I go to this lab, they won't give it to me, but it turns out I finally get the lab results. It was yesterday night, but I had no idea what it said on there because there were a lot of different, like CD45, CD138. I don't even know what BCL2 is. I'm still trying to figure that out. I have no idea.
And this was on the pathology report?
It's on the pathology report, but my oncologist conveyed to my surgeon that this was normal for a patient who had CLL, SLL. Well, I've been so focused on CLL that I don't know anything about, the lymphoma part of it. So it turned out that the tissue was lymphomic, and it was 100% lymphoma base, and it had 90% of CD5 positive cells, which I think are the B cells. That's the CLL, CD5, CD20. But you start getting to know all these things. But I have one health center that will send out all of my lab results without explaining anything. And then I have doctors that you go see where they will never give you the pathology report ever. They will call you and say, you're fine or you're not fine. But I look at this pathology report and say, I didn't even know I had any lymphomic tissue. Like, how could you have CLL and SLL? So I was so focused on CLL.
Lynn, I don't know if Lynn's taking a quick break here, because Lynn has SLL, but some people have both, but some doctors, because they're treated similarly, some doctors seem to focus more on the CLL than on if you have CLL and SLL, although they can display is the wrong word. Maybe it is the right word. You can tell I'm getting tired. They can manifest differently, whereas the SLL would shows generally more in the lymph nodes and with bulky lymph nodes versus the CLL, although I've get bulky lymph nodes, and I think Judy was mentioning that she does. Lynn, Holly was just saying about she's been so focused on the CLL, she hasn't been focused on her SLL, and she just had some pathology reports that show that her lymphoma burden is high from the SLL.
Okay, and the break point as to whether the doctor calls it CLL or SLL is the 5,000 lymphocyte break point. So when you look at your blood counts, if you're less than 5,000, you have CLL. If it's greater than 5,000, it's SLL, and it's really academic because the treatment's the same. I guess monitoring might be different because my doctor at MD Anderson depended upon CAT scans every year to be sure the disease was not active. But Dr. Awan told me, because I asked him, how are we going to track this? Are we going to have to do a lot of CAT scans? He said, not if we're able to detect it in your blood. We'll just see how you're doing by taking blood counts. So that I like that real well. And Barbell wants a sandwich with peanut butter, no jelly.
How about no bread and just peanut butter?
Well, or peanut butter on an apple.
Lynn, that was really useful information on that, on the lymphocytes. And are you talking about absolute lymphocytes or the just the,
The,
you know,
yeah,
there's,
the absolute lymphocyte count. If it's greater than 5,000, it's CLL. Wait, let me get this right. Yeah, if it's greater, it's CLL. If it's less than 5,000, it's. So in my blood counts that you look at back when I was diagnosed, my white counts were low, the lymphocyte count was low. I mean, everything was okay there. Of course, my red count, blood cell count was beginning to drop because of bone marrow involvement, and that's kind of one of the things Judy was talking about earlier. As your disease progresses, it begins to affect your blood counts, and then. And Judy's eating that peanut butter now.
Popcorn.
Something else?
Popcorn. Michelle. We found out that it's a good nutritious thing.
I love popcorn. That's usually my go-to snack at night if I'm being good.
Yeah.
So Holly, it might be good for you to come back maybe next month too. And once you maybe find out more about some of this and your blood work here, or because Lynn is familiar with that. But I do know that we have some other people in our group that have both. They've been told they have both CLL and SLL, which I think is, like you just said, that you're being shown that. So
Yeah, apparently some people don't get the swollen lymph nodes of any significance, but where others do.
and I do. I know I have anyway.
I'm concerned with Holly's statement of not getting her blood results. I mean, that they belong to you.
I think so too. And, that's part of the anxiety of, living with a chronic disease. You're always trying to be proactive. And I love seeing that everybody here is proactive. That just,
That's one of the things they give us a printout of. I would probably be jumping up and down. And
well, it's high anxiety, but I just deal with it, the best I can, even if I have to, drive down to the lab and knock on their window and say, hey, can somebody help me? So, I'm aggravating that way, but I'm also nice doing it. But it is I do see patients sitting waiting for the doctor to call them, and it just you're right. That's sad.
Got to go past being nice.
Holly, I got a question. Don't you have a portal or something where you get your results in?
I do.
When I go do lab work, I always get my results before my doctors do.
Right. So I actually got my results from my regular portal where my oncologist is, but it had to go from the pathology lab to the surgeon to my oncologist to get there. And the pathology lab wouldn't give me the results, and my surgeon wouldn't give me results. My surgeon called me and said, don't worry about anything, but I still wanted the results. So I called my oncologist, or I messaged in the portal and said, I would like my results that were given to you in your discussion with my surgeon and the pathologist. And the nurse did give it to me. And you're right. That's, some of these big systems you get into. And like Lynn said, if he goes to MD Anderson or whatever, he always has that information with him. So it's a blessing that we have the technology and the drugs both together now.
That's a
I
nice.
went up to my appointment here in January up to Mayo, and I had lab work done there. While I'm waiting for my appointment, I got my results on my phone while I was waiting there before I got into the doctor's office.
The same with us.
Yeah. lots of times the nurse would give me the CBC report before I ever saw the doctor. In today's world, the patients are a lot more knowledgeable and, shall we say, less trusting of the doctors. They want that confirmation to what the doctors are saying. And in your counts, you want to know the trend. How do they look compared to the last time that you were checked? Are they staying the same, going up, going down, whatever?
The other thing I found is going to the lab is to make sure you know what tests are being ordered, because sometimes I've gone to the lab and I said, okay, do you have so and so and so and so and so and so on orders, and there will be something missing, and they'll have to call back to the doctor's office to get that included. So it's good to know what tests they're ordering.
I had them one time say, "Oh, I missed one. Going to have to stick you again. I'm sorry. I need one more vial of blood."
So what's interesting is, so that used to be the case at Dana-Farber. And Lisa, I don't know if this happened to you lately, but twice in the last year this has happened, and that they actually can call, they actually still, even when all the results that they've tested on come in, if one has to, they forgot about one, they can call the lab and there's still blood. And they can, so they still hold whatever blood there is. And I don't know for how long. I mean, I don't know if it's, for so many hours or until after you have your appointment, but it's very interesting. Have you had that happen, Lisa?
I haven't. I'm amazed by how quickly the blood comes. It's like this, I feel like I get the blood done. I always go super early in the morning, and I feel like, there's a waiting period for the doctor, but I feel like it's like a half an hour or something, kind of like what you said, Al, like that. And I find like I'm obsessively checking on my phone and then it pops up. But the only time I've never had to like have them go back. There was one time where my blood, something happened to it. Actually, I never found out what it was. Just the readings were not good. And then the doctor had to send me back down, to do it. But I feel like they're amazingly efficient. There's just certain tests that they say take longer. So I've just had some where, he said you just have to wait longer for the, it may take a few days, but honestly, usually it's so fast. I'm shocked.
I know
it's so nice to get that feedback.
So, Mary, we have not heard from you.
Okay, so I just want to update you. I had a bone marrow biopsy and it showed no myeloma cells, but that was good news. And then I still have an M spike, which I don't know. And my light chain ratio is still high. So, these things to me in my mind don't all go together, but whatever. The doctors are happy with the bone marrow biopsy. So I'm continuing on my treatment, Darzalex, Kyprolis, and dexamethasone. And Kyprolis is known for causing cardiac issues. So I got hypertension, and we've been fooling around with trying to get that under control. And last week I went for a nuclear cardio stress test. And I guess I have to see the cardiologist to get the results. So things are just continuing, and that's where I'm at.
Sally, can anyone else hear Sally? Sally, I don't know why, because your microphone's on. We're not, that's really weird. Hold on. If Mary can hear you.
Oh, no, I can't.
Oh, wait a minute, Sally? Okay, try again, Sally. Can you try again?
Sally has to use sign language.
Hey, charades. That's really bizarre. Lou, I don't know if you know whatever Sally was going to say, or even if we could hear you. Sally, that is just the oddest thing.
Yeah, I'm not sure. One thing I was going to say to Mary, I was on Kyprolis, and it's a harsh drug. It has side effects, and
I agree.
remember, I believe in making sure you investigate things. When the doctor puts you on something, I want to know what that drug is, what the side effects are, everything about it. And I remember going to the website for Kyprolis, and the first thing you see, the drug company that makes it, the first thing you see is this big banner that it can cause cardiac problems. And I'm just like, whoa. And I was like, I thought, it's bad enough to have a disease, that has to have, chemotherapy and different kinds of drugs and is hard on your body. But to have a drug that also can add to your problems, I have something inside me that says that's wrong. When you have to take a drug that causes you more problems, I worry about that. Kyprolis, I had to wear like a heart monitor for 2 weeks because I had a little arrhythmia. Never had it before, that drug. So that was, concerning. But it caused my triglycerides to go from 150 to 200 was my normal triglyceride level. It went to 5,400,
Wow.
which is stroke level. And I was teaching at the time when I was on it. I got a call from the doctor's office when they ran tests because I kept saying, something's not right, something's not right. And they finally tested triglycerides because I said, they're seeing fat, literally visually. The technicians are seeing fat in my blood. I said, something's wrong. Something's not right. They couldn't run tests. They couldn't do the lab tests at the cancer center. They had to send it over to the hospital where they had a super duper fancy, what is that, centrifuge machine that spins the blood and separates it and all of that. And so I was at risk of a stroke. And the nurse's office called at school, and they never send calls through to your room typically anymore, to talk to a teacher because you have students. And so she asked to be sent through and said it was an emergency. And they had me come to the cancer center, run tests again, and my triglyceride level was even higher. It was like 5,600 by the time I got to the doctor's office. So if you're on Kyprolis, please have them run your triglycerides. I talked to the manufacturer, the drug manufacturer, and they assured me that in none of the clinical trials did they have that issue. Well, I said, you know what? I could be first. And my doctor did send all of the information from my tests and everything, and he took me off of it, obviously. And immediately within a week, my triglycerides went down to 600 immediately, that fast. So you have to be your own advocate. You have to keep saying something's not right. Something is not right. Because you know what? They have a lot of patience. And if you don't, keep saying something's not right and insisting things are looked at, who knows where you would end up, So good luck with Kyprolis.
Well, my problem is I have high risk cytogenics. I have 3 of them, and so they have to be really aggressive. And
Yeah,
that's
I did too. Yeah.
Yeah, that's why I'm where I'm at.
Yeah.
And so,
Yeah. I've been there too. So yeah.
okay.
Translocations and yeah, genetics that weren't good. I think it was here we come upon St. Patrick's Day coming up. I blame my Irish chromosomes and
Glad you didn't walk up and shake
genetic.
my hand today.
I'm yeah. McCarran was my maiden name, and my ancestors came from Donegal, County Donegal, which is far, far north. And I always blame, we had bad nutrition. My ancestors had bad nutrition and were often starving, obviously. And so I blame my Irish ancestors for sometimes, not passing down the best of genetics to me. So anyway, I'm kidding, obviously.
So I'm going, Mary, I don't know if you're looking at the chat or not, because Sally has sent you a message.
Okay.
So if you're not, I'm going to read it to you. She's saying your M spike can remain in your blood, even if it's no longer being made in your bone marrow, and that it takes a while to leave your blood.
Okay. Good.
And she says that she'll email you tomorrow. Congratulations.
That's great. Thanks.
Sally, I'm now your voice. Sorry. Sounds like, but Lynn had to leave because they had company. But I know, so Jim and Al, Jim, what I know you wanted to share with us. Thank you so much for hearing us all out.
Oh, that's okay. Anyway, I am the strange one in the group. Actually, I am here for my sister, um, who has, MM, but she refuses to attend. So then anyway, I am a prostate cancer stage 4, essentially in the lymph nodes. So anyway, I have been medically castrated for 5 years, which means I've got no testosterone in the body. And so I decided to take a treatment holiday. Okay, and the doctor at first just exploded. You can't do that. And I said, oh, yes, I can, because I found a study through here and AnCan that highly recommends that you take, a treatment holiday. Otherwise, there is about a 15 to 20% chance that the drugs I'm on would then cause the cancer to become a small cell neuroendocrine, which is an SOB of a cancer. So she says, oh, I didn't know that. Thank you very much. So right now I've been on and with Holiday for about 6 months or so, and it's great. Although still the testosterone is still 0, and that's good. So I just continue on and we month to month, and I get the testing. And so today was the day I found out everything's good. So life is good.
Oh, that's wonderful, Jim. And your sister's lucky you're here for her. Someday, she's going to surprise us all, I think, and show up.
I hope so. I hope so.
You're so wonderful to attend on her behalf and to listen to all of us and listen to all, more than what your sister has, and you don't even have a blood cancer. So we appreciate you here.
Surprisingly, and the VA considers that any cancer which is within a lymph node, they call it non-Hodgkin's lymphoma, which is interesting. So according to them, maybe I got one, but so, hey.
Well, you're with us for the long haul. We know that, Jim. So you're,
Sure.
we don't want you to have a blood cancer, but
No.
we're
I have
happy
enough issues on my own.
you do. You do. Al, you have been waiting patiently there in your movie director look.
No, I've just been listening to everybody's stories, which is great. We'll go back to this is a distant relative of mine. It's my wife's cousin. And in January, she was diagnosed with essential thrombosis, which I would call the first phase of the MPN. And so a nurse raised the red flag that her platelets and red blood cells were elevated way back in 2016, then again in 2020, and she went in for a health screening this year, and they were high again. So they scheduled her for a bone marrow biopsy, which she just had probably like 2 or 3 weeks ago. And so I got to talk to her. I didn't want to burden her and be calling her and sending her messages, but I told her if she ever wanted to talk, call me, message me, anything. And I was able to talk to her. And what I did she does live in Phoenix. And I told her, I said, your hematologist is going to call you in and go over the results with you. When he does that, you ask him, you want a second opinion, and ask him to send your results over to the Mayo Clinic, because at Mayo in Scottsdale, they have a special MPN team there. And the doctor told her, well, nothing came up in the bone marrow, so we'll check it again in 6 months. But anyway, that's where she's at. And with this disease, that's what I do know. This journey is a roller coaster. Everything it's up and down. You feel good one day, and then I'm down for a couple days. I'm down for like 3 or 4 days a month, and then I feel good. But anyway, with some of you knowing the results of bone marrow biopsies, is this normal for it to come back? Not negative, but there was nothing showing, and they're going to run another test again. And, so like her mom says, wow, she's got nothing. So like right now, they're all at ease that she's got nothing. Me knowing the disease, it's there. It's just waiting to transform and progress. But back to the question of any of you knowing anything of the bone marrow biopsy results.
Well, how did they find out she had ET?
From her lab work earlier this year. One of the doctors diagnosed her with ET.
Do you know if she has a JAK2 mutation?
She does not.
Oh, she doesn't. Okay.
Or at least she wasn't told that. And she did send me her lab work earlier. She says, this is my lab work. Yeah, there was no JAK2 mutation.
I know Sally is trying to tell us something again. All I know, Al, is, she's typing it. I know, for instance, when they're for CLL, a lot of it is dependent on the cells harvested at the time. If there isn't much disease, it's hard to tell if it still is infancy stage. I just know with genetic marker tests. And on but you're saying they're picking up things on her blood work, but on the bone marrow, they're not. And I think the bone marrow is more of a sensitive type of test. But again, if there's hardly any and they take a specific piece of bone marrow at the time and the sample of it, the tissue sample I'm unsure, but it sounds like if they're not seeing it, perhaps there isn't much, if any, there. And that's the ultimate way to diagnose, right? Is that correct? Or
Yeah, I have no idea. And again, and I'm in about 3 groups left in the Facebook support groups, and that's what's brought up a lot. Is a lot of these people with PV are describing their symptoms, their treatment, and everything, and a lot of the comments are, do not be treated by your primary care. Make sure you get an MPN specialist. A lot of doctors do not understand this disease.
Did you see what Sally wrote?
pretty much something similar. That it's on the bone marrow biopsy. It can be wrong if it's not populated in the biopsy. The cells aren't equally distributed.
And so like the next time I run into her, we talk, I just want to let her know, get your results and you yourself send them over to Mayo or make an appointment with the doctor there and take them with you. It's just, to me, it's not fair that if they didn't see it, are they going to put her through another bone marrow biopsy again? I don't know, and again, it's the doctors. They don't understand this. So there's a list of it. I'm sorry?
I would get a second opinion.
Yeah, that's exactly, yeah.
Absolutely. I would hightail it over there in a heartbeat.
Yeah. So there's, they post this on the Facebook groups, the list of the MPN specialist. And those 2 doctors you spoke with, that you sent me the videos with, Michelle, they're on that list. And also my doctor was one of the speakers at the ASH conference. And she's on that list also.
So for your relative then, that's interesting. Yeah. It's so they should be able to help, one would hope, and to diagnose her.
And to start treatment right away. Why wait? Start the treatment sooner. She does feel tired. She has the fatigue. So there are some symptoms.
Is she willing to go the extra mile to pursue it and self-advocate?
At this point, I don't think so. What is she? She's 48. She had a lot of anxiety, waiting for the results, waiting for the next step, this and that. And so now that she went in and the doctor says, we don't see anything, well, they're all relieved. And I'm saying, no, not yet. She needs to get that second opinion from a specialist. I don't.
Yeah,
I don't.
She does need to see a specialist. And I know there's lots of talk on the different support groups that it doesn't matter, but personally, I believe it does.
Okay, Al, another comment or another direction from Sally, a question. Okay, see it?
Oh, do you know she had a targeted BMB with an X-ray?
Yeah, that I don't know. Yeah.
Sally seems to think it makes a difference. Yeah. Oh, yeah. She's shaking her head.
Same with CLL. And there was this whole discussion on one of our social media groups, the CLL support group, where people were defending their doctors who were not specialists and saying they were happy with them. And and it would be, how can one hematologist, oncologist know all the ins and outs of every single blood cancer and every single drug and keep on top of all the new drugs versus just going to someone where that's what they do and that's their specialty. So I would say the same. Well, and you know it, Al. So yeah, you
No,
can tell her that we're all in agreement.
no, you're absolutely right. I mean, you interviewed two of the top doctors for MPNs.
It was MPN year, it seemed.
Yeah.
It hatched this year, and multiple myeloma. Not so much for CLL. Lou?
Yeah, I don't know if they have a study on file for CLL or, leukemia specifically, but they do for myeloma. They did, there are a couple of studies that investigated, does it make a difference in your lifespan if you see a specialist? If you see like a myeloma specialist or a specialist in your whatever disease you would have, and it made a difference. I think it was 2.5, Sally. I don't know if you remember seeing the study. I think they had it on HealthTree as well, or through IMF, and it showed that your life expectancy could increase by 2.5 years or something. I mean, if it makes a difference in how long you can live, was it 5 years? If it makes a difference on how long you can live, isn't it worth getting a specialist? Just throwing that out there.
There is a study in CLL as well. So we have the same results. You live longer if you are treated in a center by a specialist.
Yeah, I'm a CPA, but I'm a corporate accountant. So you would not want me doing your taxes, I promise. So that would be kind of what she may relate to. So just tell her, do you want to see a CPA that specializes in taxes, or do you just want to go to a regular one? But that's kind of the same thing. You specialize in one area and or it's very broad, but you don't get the sense of the information. I agree.
I think there's value in having a local doctor. I'm saying this, I don't have one, but having a local doctor who is a cancer specialist, specialist, an oncologist, to help you with the kind of the local support, but you want your treatment to be directed by a specialist. I mean, that's my opinion.
Yeah, I make the drive for 2 hours to see my doctor.
My drive is now 3 hours instead of 7.5, but I know what you're talking about.
Yeah.
An hour.
At
Michelle
least
just gets on the subway.
actually, the subway would take a long time because I'd have to switch a few times. So but by driving, if
Well,
yeah,
maybe you could ride the subway and meet up with Lisa, and y'all could stop and have coffee somewhere.
I know. We'll figure it out. I have met people that I've never met before, but knowing them from like our support meetings or support groups and just running into them at Dana-Farber. So it's really interesting to get to know them. Or I can travel to Ash and meet Holly, There's nothing like that though.
Well, the next time Judy and I meet at UT Southwest, I'll bring my guitar and we'll sing a song and record it for y'all.
Oh, would you really?
Judy's muted. She said something.
We actually reminisced and knew some of the same people, so that was kind of interesting.
Also, take a picture.
That's right. And Lynn, you'll be there in 4 months. Judy, you'll be there. You go every 2 months. So maybe at your second 2-month appointment, you and Lynn can coincide again. And Lisa, I'm at Dana-Farber next Tuesday. I don't know if you're there, but then I'm going to be there a lot for the next month and a half. I'll be there a couple of times a week after that.
Oh, so maybe we can, I have to go in there for blood work. It's I don't know, sometime in the next few weeks. And then, but my next official appointment really is May.
So let me know. And everyone,
So-
wish me luck. I have an appointment, a big appointment next week, but I'm starting, it looks like obinutuzumab in 2 weeks or week and a half.
Are you taking only one drug or are you going to do a combination?
I'm already on acalabrutinib,
Oh, okay.
and I have been for 15 months. And my doctor since the start has been pushing for me to add on the obinutuzumab. So I guess it's time I finally listened. And that's so I avoid a transformation.
Right. You don't want a transformation, believe me.
I know. And when you heard that, I was like, okay, I guess this is the thing I needed to hear.
Yep. 'Cause
So
the treatment for that is much harsher than just taking an infusion.
what's another 6 months of yet another infusion, you know? I mean, seriously, when it comes down to it, that's how I have to look at it. So anyway, Lisa, just let me know.
It would be so nice to me. I would love it. That would be great. And it's not that hard for me really to drive into Boston, truthfully, you know.
And we're lucky that we have it so close compared to the different commutes that we're hearing here.
I know.
Well, anyway, thank you, everyone. Did anyone have anything else they wanted to share this evening before we sign off? Well, until next month, first Thursday of the month, let me see, what day is that? That is, oh, wow, April. Maybe it'll be warm, April 6th.
Happy St. Patty's Day, everyone.
We've had 80s this week, but it's just dropped about 30 degrees this afternoon with a really heavy storm this afternoon.
Wow. Well, thank you, everyone. And we'll see you April 6th. Bye.